Hello everyone, my name is Steve Wiland. I'm a licensed master's social worker and an internationally certified alcohol and drug counselor. And I'm here today to talk about the very important practice area of providing treatment for folks with co-occurring mental health and substance use disorders. There have been many models that have been featured over the past 10 years, both nationally and in the state of Michigan. And part of how I'm going to structure the presentation today is to kind of walk through different models that have been featured at different times within the recent history of the state of Michigan that were intended to help develop and implement good integrated treatment for co-occurring disorders. Some of you who have been around in the CMH world for the last decade or so probably remember Ken Minkoff, who is a nationally recognized leader in the area of integrated co-occurring treatment, and really one of the pioneers for systematically developing an approach that would integrate mental health and addictions treatment services in a way that could best serve somebody with co-occurring disorders. Ken Minkoff made the rounds to various places in Michigan providing training and consultation, and much of what he helped to establish as a foundation is still very valid today when we talk about how do you design services and systems and adjust organizations to be able to best serve those with co-occurring mental health and substance use disorders. So I want to start out by walking through the 8 different practice principles that Dr. Ken Minkoff really used as the foundation of his integrated approach. And the first of those 8 principles is that dual diagnoses or co-occurring disorders is in fact an expectation and not an exception for the population served by Michigan's community mental health provider network. And what's intended by that is that significant research both nationally and regionally has shown that for every 2 people that walk into the front door of a CMH provider network agency, at least one of them has a problematic substance use disorder in addition to whatever their presenting mental health disorder may be. And that kind of prevalence has shown itself to be the case across time and across different settings. And in fact, some of the prevalence findings are even higher than that. For example, assertive community treatment teams, ACT teams, as they're sometimes called in the state of Michigan, the prevalence of ACT consumers with co-occurring disorders tends to be higher than 50%, in some cases as high as like 70 or 80%. And so treating co-occurring disorders as an expectation rather than an exception it just makes sense. And we need to be prepared as practitioners and as programs and provider organizations to expect that perhaps the majority of people who walk into our front doors who are referred to us by our system may in fact have a co-occurring substance use disorder in addition to their primary mental health disorder. And to have the service array and the knowledge and practice expertise that is needed to be effective in serving those folks is what we're after when we talk about developing and implementing good co-occurring care. This slide just shows some of the research findings dating back to 1990 that helped to form the evidence base for knowing that the prevalence is as high as it is. A couple other research studies worth considering when it comes to establishing the prevalence rate. And if you're already convinced of this yourself, that's great. This is review for you, but it also could be good evidence that you could point to if you're having the discussion with somebody else, a coworker, a colleague, somebody from another agency, somebody who's a family member or community stakeholder who may not be aware of the reality that the prevalence of co-occurring addictive disorders is as high as it is among the mental health service population. So this slide shows prevalence among the general population of different forms of mental illness and different types of substance use disorders. This is from an older study, most recently updated in 1997, but the figures have not changed a whole lot. On the mental illness side, depression and anxiety tend to continue to be the most prevalent mental health disorders, some depending on the level of severity that those disorders is defined by. Some studies have findings as high as 19 or 20% of the general population experiencing depression or anxiety over the course of a lifetime. For bipolar and schizophrenia, again, depending on the level of severity that's in view, those prevalence rates sometimes edge upward 2-3%, but generally in that range, even in most recent studies. On the substance use disorder side, for alcohol and then illicit drug use or abuse, the findings are consistent that more men than women abuse in both categories, but generally 1 in 5 of the general population is diagnosable with a substance use disorder over the course of a lifetime, and somewhat less for a drug use disorder. So there's been studies done from both directions, okay? So there's been research done for folks who are receiving services from a mental health provider and looking at what percentage of those folks have a co-occurring substance use disorder. And then there are studies that are done from folks receiving services from a substance abuse treatment provider, looking at what percentage of those folks have a co-occurring mental health disorder. So we're going to look at some of the research that's been done from both of those directions. In terms of folks who have identified mental illnesses, who are in treatment for mental health disorders, who are found to have substance use disorder, this is the findings of a study that shows the general population on the first column there, and then compared to folks with a mental health disorder of one sort or another, showing how much more common it is for folks with those mental health disorders to have a co-occurring substance use disorder as contrasted with the general population. So not surprisingly, the mood disorders are found to be pretty high co-prevalence with folks with a substance use disorder. And why I say not surprisingly is because it is theorized that folks who are experiencing distressing symptoms of mood disorders, either too far up, too far down, may attempt to self-medicate those symptoms by consuming a substance that they believe will help bring down their manic mood if they're too up and elevate their depressed mood if they're too down. And that is the reason that we hear many clients report as to why they may have started or increased their use of a mood-altering substance to try and self-treat, if you will, the symptoms of a mood disorder that they're experiencing. But also, in the case of schizophrenia, obsessive-compulsive disorder, panic disorders, you also see that the prevalence of substance use disorders among those populations is higher than the general population. This is a study done that teased apart different types of substances and how prevalent their use was among psychiatric treatment patients. And again, you can see the variance between the different substances, but the green bars there show any substance use disorder. And if you look at the axis on the left there, for percent lifetime prevalence of substance use disorders, you can see that it's 50% or higher for any substance use disorder for folks who have each of these different mental illnesses. So again, more evidence that backs up Ken Minkoff's assertion that co-occurring substance use disorders is an expectation among the mental health service population, not an exception. So how about from the other direction? This was a meta-analysis of several studies done, encompassing almost 5,000 teenagers and almost 2,000 adults, of individuals who were in services for an addictive disorder, trying to answer the question, what is the prevalence, the co-prevalence of a mental health disorder among these populations? And 2 out of 3, across these 77 different studies, 2 out of 3 individuals receiving services for an addictive disorder also reported symptoms of a mental or emotional disorder. So no matter which way you go at it, you find a high co-prevalence. This study also tried answering that question for folks who are in services for substance use disorders. What was the breakdown of different types of mental or emotional illnesses that were co-prevalent? And as you can see, mood disorders, that bottom bar there, was the most highly co-prevalent. And the breakdown of other disorders, phobic, anxiety, panic disorders, et cetera, is how it shows here. This is a very interesting finding. Every year, the United States government conducts what they call the National Survey on Drug Use and Health. And it's an anonymous, phone calling kind of survey. Thousands and thousands of folks are called up randomly across the United States and asked if they would be willing to answer questions that have to do with their substance use behavior, their mental health status, and so on. And as of 2002, which is where this slide is pulled from, and every year since, more people reported having co-occurring mental health and substance use disorders than reported having just a mental health disorder or just a substance use disorder. So it's not maybe the most scientifically rigorous study, but it's one of any number of findings that we've been looking at that shows how highly co-prevalent mental health and substance use disorders are. The second practice principle that Ken Minkoff really kind of helped to raise awareness on, and this is somewhat intuitive for anybody who has worked with a mental health or substance use population, that dual disorders lead to worse outcomes than single disorders. And this is not to compare distress or compare pain. That's not typically a useful exercise. But what it is to look at the findings of many, many different indicators. I think it's somewhat intuitive to understand that if somebody has a mental health disorder, they are at higher risk for developing a substance use disorder in ways that we've already touched on, self-medicating different symptoms and whatnot. And I think it's also easy to understand that somebody with a pre-existing substance use disorder, because of the effect of those whatever chemicals are involved on the brain and nervous system over time, that puts that person at higher risk for developing particularly a mood disorder array of symptoms. And so if somebody has both disorders, I think it makes sense that if they're trying to recover from one or the other of those disorders and they struggle in one or the other of those areas, they're at higher risk for relapsing in the other area. So for example, if somebody is addicted to alcohol on the substance side and also has an independently occurring major depressive disorder on the mental illness side, if they aren't consistent with their treatment for their depression, taking medication as it's prescribed, following through with therapy and whatever other supports or services that they're connected with, the distress that they would experience from their untreated or undertreated mental health symptoms could be a precipitant or a trigger to using alcohol. And conversely, if somebody's using alcohol and the effect that has, the intoxication syndrome, the withdrawal syndrome, the corrosive effect on major domains of life, it's easy to understand that that could lead to greater depression for that person as they struggle on the one side. So there's an increased risk of relapse for both mental illness and addictive disorders for somebody who has co-occurring disorders.